Dr. Turner, thanks for joining us. Nice to see you again, as always. The subject is incontinence, and it's maybe not the best dinner conversation, but what is stress incontinence? How does it differ from other forms of bladder incontinence and bladder control loss?
Stress incontinence occurs when you have an increase in the intra-abdominal pressure. Things like coughing and sneezing, sometimes arising from a sitting position, bearing down. At that point, you increase the pressure in the abdomen, puts more pressure on the bladder. The connective tissue that supports the bladder, and sometimes even the muscles inside the urethra, are just not strong enough to handle the extra stress, and you squirt a tiny little amount of urine.
You're a gynecologist. This suggests that perhaps this is a problem more common among women. Is that true, and if so, why?
That is true. Pregnancy, childbirth, and around the menopause, loss of estrogen. The concentrations of estrogen start to fall in your 40s and 50s and 60s, and sometimes that fall in estrogen is just enough to make something else that was there worse, and you begin to notice things that you weren't doing 10 years earlier.
You might have segued into our next question. What are the risk factors for stress incontinence?
Predominantly, it is pregnancy, childbearing, and loss of hormones. Now, if you want to do trivia, even parachute jumping, women who are parachute jumpers will have some stress incontinence, and it occurs when the parachute deploys, that sudden jump.
Right.
Yeah, that's the trivia question. Since we don't have too many paratroopers in our audience, it's usually just pregnancy and childbirth.
And you touched on this, but let's put some color to it. What causes the loss of control?
The loss of control is that you've got some support structures to the bladder and the urethra that drop. And so as a result, the whole sphincter mechanism and the continence mechanism is broken. I like to describe it as imagining a water balloon. And if you've got your finger over the water balloon, you can hold it like this and you can keep it squeezed off. Well, when that bladder, the neck of the urethra drops and the water balloon is up here, a lot more pressure comes and it's going to squeeze out that way. And that loss of the urethral vesicle angle, that loss of the connective tissue surrounding the urethra underneath the pubic bone, is the main thing that we see in most women. Now, sometimes there are tears outside the bladder, all out on the pelvic floor, and everything just comes sliding out.
What's the link between menopause and all of this?
The dropping hormone levels. And so I would even take that back to the perimenopause. 4 to 5 years before you really have your last menstrual cycle, those dropping estrogen levels sometimes may be the thing that tip it over.
And so with this condition, how do you make a clinical diagnosis of stress incontinence?
The clinical diagnosis is done taking a good history and physical, and when you're on the physical exam, you can begin to see how the changes in architecture have occurred. A thorough gynecologic exam will involve my looking to see where all the connections for the support of the pelvic floor lie, what fractures literally may have occurred in the connective tissues that hold things in place, where things have been stretched out completely, how that 9.5-pound baby just kind of split everything apart. The pelvic floor has some degree of stretch, but sometimes it's that 9.5-pound baby that stretched things out so far that something just broke and gave.
With that examination complete and with your diagnosis in hand, how do you treat it?
The first thing I offer every woman is, in fact, I'll even start offering it to my patients on their annual exam in their mid-20s and 30s, is just being able to do a good Kegel exam. I imagine the Kegel as that tightening of the pelvic floor.
You mean the Kegel exercise?
Yes, sir. Thank you. I imagine those Kegel exercises as being the opposite muscle group to the abs.
Okay.
You tighten your abs, well, your pelvic floor has to be able to handle the extra pressure.
Right.
And so you shut off the muscles that shut off your stream of urine are what we usually consider the Kegel exercises. And so just being able to do that, just practicing that, will help strengthen those muscles.
And so what kind of frequency and repetition of that?
Oh, I used to joke 3 sets of 100 a day. 1, 2, 3, 3, 2, 1, 3, 2, 2, 3, 2, 3. And I had a medical assistant who used to say that she always did it at the stoplights. So you can do it while you're washing dishes or things like that.
Beyond that, when is surgery an option to deal with stress incontinence? I
offer surgery when conservative measures have failed. Kegel exercises. Occasionally I'll have patients who need physical therapy, or they ask for physical therapy because I literally have to have someone to teach them how to recruit those muscles. Sometimes the damage of childbearing will break the nerves that are connected to those muscles, and it takes some effort for them to learn how to tap that muscle. It's like imagining how you teach somebody to move the muscle that's going to move your finger. Same thing. They have to learn how to reach that muscle that's in the pelvic floor.
Are you literally talking about reestablishing contacts?
Exactly.
And that can be done?
Sometimes it can. Sometimes it can. A really good physical therapist, and we have one out here at UT, can help those women learn how to improve their Kegels. And if I can get a physical therapist to teach my patient how to do that, and that can save her a surgery, that's one other thing that helps. In my elderly patients, sometimes I'll offer them a pessary. That's a little rubber device that helps hold things up in place. And in that case, they're perfectly happy with that. It makes them feel better. They don't have everything falling out. They just don't ache. They just don't hurt. And the pessary is sometimes all that an elderly person will need to correct their stress incontinence.
But in the unfortunate case when that doesn't work, what do we accomplish in surgery?
In surgery, I like to go back and try to restore the anatomy of what was broken during childbearing, during delivery. And that involves going out and finding the connective tissue structures that have fractured, or the things that have broken apart. And that's an intricate dissection. But I think that's probably what we really strive to achieve when we do a good surgical repair. Now, there's a couple of procedures out there that are really reliable for the cystourethral. That's the transvaginal taping and the transobturator taping. The slang terms for those are TVT and TOT. And those are well proven, those are good quality operations, and they're day surgery procedures that can be done in a day surgery or a 23-hour observation setting.
And what kind of outcome do we?
Oh, usually pretty good 5-year outcomes, over 85–90% consistently.
Very well. What can a woman do herself to deal with and improve bladder control?
Starting out with Kegels in their 20s. Really, just being that in tune with your body and taking good care. Sometimes adding estrogen, vaginal creams. You don't have to worry about any consequence. I can almost say point blank, you don't have to worry about consequences from a half a gram of estrogen cream twice a week. That when you're getting in your menopausal years. If you have a breast cancer, there are therapies that we can discuss with your oncologist when you start having really bad symptoms along those lines. One other type of urgency I want women to understand is that stress incontinence is when you increase your abdominal pressure and you're stressing or bearing down or lifting up a grandchild and all of a sudden you have
sneezing, coughing,
jumping up and down sometimes. Now it's the 15th jump that will cause what we call urge incontinence. That's a sudden urge to go to the bathroom. Okay, that's when you almost make it to the back door when you're driving from home. You put your foot over the transom and you're in the kitchen and it goes. Yeah. Complete loss of everything. Big puddles. No, that's urge incontinence. We can treat that with medications. Estrogen cream makes a big difference in that. That's different from stress incontinence.
Very well. Doctor, it's always an education. Thank you very much.
It is, sir. Thank you.